Good evening to each and everyone over here. I am thrilled to welcome you all for the today's informative webinar on mastering airway management. I am Vijay, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker of the evening, Dr. Kunal Kumar. Dr. Kunal is a seasoned physician with over 17 years of experience in internal medicine, critical care, and family medicine. He holds an MBBS from Rajendra Institute of Medical Science and a Master of Medicine in Family Medicine from CMC Vellore, along with certifications in diabetology and critical care. Currently serving as consultant in critical care at Paras Hospital, Ranchi. Dr. Kunal is also skilled in ICU management, emergency procedures, and patient centered care. We welcome you, sir. Thank you so much for joining, and I would hand over the screen to you.
Thank you so much. I was a little, just away for a couple of minutes right now. I just had a call from the hospital.
That's fine,
So
sir.
I just got to hear the introduction. Yes, the Srini has given about me, and I would love to give thanks to all of the team of Mediversal team and for joining me as a teaching faculty. Before that, I was a student here. I have pursued here for a sports medicine because since I had an experience in sports medicine. I worked in ICU uh, in TMH hospital, and during that period, I had also worked for a Jamshedpur FC football team. And, and during that period, I had an experience of sports medicine, and I have also seen people, healing themselves with so many such in a physical way. They don't have much options for medicines since they have to go through the WADA test. There are certain drugs which we cannot use in sports medicine, which we use in a normal clinical scenario. So yeah, uh, so I had an experience in sports medicine. So I also took up a course from Mediversal Academy in sports medicine. So today, I like to see all of you. If you can turn on your cameras, so that I can see how many people are here. In the class. If you're comfortable, otherwise, just to see the participation. Nazrin Parveen, Kirti, Kirtika, Kirtika Verma. Okay, and I can see only two people till now. Well, it's good to see all of you, and I would love to come directly to the topic. Ifka, can you please share me the? Yeah. So we had an today's topic is in like how to manage airway in our clinical scenario. Hi, good evening. Good evening, Jadid. Uh, it's good. It's good you are traveling and at the same time you are attending the session. It's good to see that.
Doctor, 1 second. I'm sharing the screen. Sorry, 1 second. Doctor, I think you are mute. We are not able to hear you. You are mute. Uh, Doctor, can you try to unmute yourself now?
Yeah, now it's done.
Yeah.
It was unmute from your end, I guess. So I hope everyone can see me and hear me at the same time. Is it okay? Sound? Hello?
Yes, doctor, you are audible.
Okay, am I audible right now? Yeah,
Yes.
good. So how many of you, I just want to know, like, um, are you still students, medical students, or you are practicing somewhere or going to some kind of post-graduation? Okay, just Sankalp Sinha, Dr. Can you mute yourself? Yeah, the sound is coming from. Yeah. Okay, just completed his graduation. So yeah, who else? Even if you are a trainee, okay, yeah, in emergency medicine, very good. So Chinit, it's a very good course for you. I mean, the class for you, it's going to be very, you know, for you, it's going to be very informative. And okay, Kritika Verma, OBG. So whoever, which department? Okay, Ganesh, intern, working in resident. Okay, CM, okay, emergency department. Nice. So there are people from variety of branches. Yeah, HOD physiotherapy. Nice. Ratnesh Chaudhary. Yoga and holistic. BDS. Yes. Okay. Arif, Ayush, bachelor pharmacy. So it's good to hear. Thank you, all of you for sharing your, your information. And it's good to see all of you people like from various of departments. And so whichever department you are working and whichever department you are in. So if you are working in hospital or even in a ward or even in any department, emergency medicine and ICU, this is the part of it. But even if you are not working in ICU, even if you are not working in an emergency department, in a hospital, even if in the wards, you will find patients getting all of a sudden deteriorated and patient collapsing, and there will be respiratory distress. The patient is not maintaining saturation, patient is tachypneic, patient despite of giving oxygenation, you are not being able to manage the airway. So for those people, this class is going to really helpful in their clinical scenario. So today's topic is airway management. So in this topic, we will cover the indication of endotracheal intubation, why we should intubate a patient, why we should go for a endotracheal intubation. So we have certain indication for that. And then we'll go for the how airway management in ICU patients are different from other in OT, operation theater. In operation theater and in ICU, there are a different scenario. Okay, so we'll have to see that the how airway management is critical in ICU. Okay, so and what is going to be the complication of intubation in ICU, during intubation, after intubation. Okay, and we also have going to see the assessment of airway, whether it's patent, it's in place or not. We'll have to see the assessment, because once you have intubated the patient, you have to assess the patient has been intubated properly or not, because the circumstances after intubation has to be very grave if you haven't done intubation properly. Just pardon me. Can you hear me now? Give me a thumbs up if you hear me. Yeah. So one by one, we'll go for each and every section. So complication of intubation, then we'll assess the airway. Then we also see the drug and equipments which are required for during for the airway management. And we also see the algorithm. If you're found difficult in airway management, then how you going to proceed and how you going to plan for the airway management. So there will be plan A, plan B, plan C, like that. So in algorithm, we'll have to select either the subglottic devices, and the last resort is cricothyrotomy. Okay, and so what is intubation bundle and how does it work? So the intubation bundle, it was described in 2010, and the study, it has worked or not, we'll have to see in Indian scenario how it's going to work or not. So let's proceed one by one to the our section of airway management. So what are the indication why you need air management in a patient? So the facilitation of this is the first indication of intubation. There will be, most commonly it will be like we have to facilitate the invasive mechanical ventilation. A patient which requires mechanical ventilation has to go for intubation. See, so for the mechanical ventilation, we have to intubate the patient or we have to secure the airway. Okay. So for that, there will be the reason behind that, there will be inadequate oxygenation and there will be inadequate ventilation. The patient might be in shock or cardiac arrest. Okay, and sometimes you need a controlled hypoventilation, because sometimes you have to see some patients from neuro department, head trauma and all that. So patient will be hyperventilating and CO2 will be retained and going type 2 respiratory failure. To prevent that, we have to sedate the patient and paralyze the patient and have to intubate the patient. So the GCS below 8 is a indication for intubation. Two, if a patient comes to you with a head injury with low GCS below 8, there is an indication for intubation. And any need for a neuromuscular paralysis or post-operative elective ventilation. In a supra major surgery, we have to go for a, we need to patient to be sedated properly so that the operation should go on. And for the anesthesia, and the anesthesia, if you're giving anesthesia, there is chances of developing respiratory failure. So to prevent that respiratory failure, we have to go for a intubation to protect the airway. So and our next indication is to protection from our airway from the aspiration. So there sometimes there is a patient with a gastric reflux patient and with a low GCS coming, and there is a chances of having gastric reflux, getting that gastric content into that respiratory tract, and there is a chances of developing that aspiration pneumonia. For those kind of patients, we have to put that patient in a intubate. We have to intubate the patient and put on the ventilated support. And next is a tracheobronchial toileting. If there is already some debris or any kind of mucus plug, hypersecretion, and there is a that is obstructing your airway, and there is a continuous secretion, there is a continuous aspiration coming out of your GI tract. So for that also you have to do the tracheobronchial toileting, and for that you need endotracheal intubation. And to relieve the upper airway obstruction, definitely if you put an intubation, if you put the tube then the airway obstruction definitely get relieved. So let's come to the case. Suppose you are working in ICU, or and there will be case coming to you, a 60-year-old male patient of 80 kg. He is a diabetic male. Can you go to the next slide? Yeah. So there is a patient coming to ICU department from emergency. They have sent you. It's a 80 kg diabetic male of 60-year-old, and he is coming with a lower pneumonia, and he has been shifted to ICU, and with complaint of progressive breathlessness, altered mentation for 6 hours. He is drowsy but arousable. His respiratory rate 33. He is tachypneic, and his saturation is on borderline. You can see 92%, and with a face mask, O2 6 liter per minute, and the heart rate is 110 per minute, and blood pressure also in the lower side. So the we will check ABG first. Yeah, we will come to the ABG. Yeah, definitely we will check the ABG. How will you manage the patient? But after seeing this class, you will have different point of view. Okay. We definitely see the ABG. There are battery of tests we can go for, actually. But in the patient where the patient is collapsing with a oxygen 6 liter, and patient is in shock and altered mentation. So definitely we will go for ABG. If ABG is available, we'll have to see the oxygenation and CO2, whether the patient is in type 1 and type 2 respiratory failure, or what kind of acidosis he is having right now. So there are various kind of information you can get it from ABG. If you are working in ICU, I'll take a additional class for ABG. Don't worry. Please go for the next slide now. So how will you manage the patient? So now we are working in ICU, and there is an intubation in ICU and intubation in operation theater. There is a two different scenarios, and very different scenario. Like in a intubating, you are an ICU operation theater OT room. It will be very, there will be people around you. There are skilled anesthesiologists. There will be generally a stable patient, will be stable, not serious like in ICU. They get the patient for OT. Even if you, in a clinical scenario, if you see that, the surgeon will come and say, let the patient be stable, then we'll take for OT. So they take stable patient to the OT, and for the anesthesia, the patient has to be fit, okay, with a good physiological reserve. The patient should have a good physiological reserve. Blood pressure, pulse rate, saturation level, respiratory rate, counts, everything. Like there has to be some patient has to be stable, not critical as ICU. And mostly the effective intubation. Okay? So we go for this kind of patient, and mostly their intubations are effective. Okay, and there will be optimal conditions over there in OT room. But what you come in ICU, the patient coming with a sudden cardiac arrest, sudden heart attack, sudden with a low GCS shock. You'll have no time. You'll have less people. There will be 16 bedded ICU, maybe 4 or 5 sisters working over there. Few people, maybe they are not experienced. Maybe you are not experienced. Okay, so there will be lack of experienced people, varying scale of level. If the consultant is available, then it's good. If consultant is not available, if you are not skilled enough to intubate, you will get stuck in this kind of situation. So intubation in ICU is very critical. There will be patient very unstable. There will be varying skill levels. There will be people with no physiology. The patient will be there with no physiological reserve. So there will be little or no time. There will be very less time for you to prepare for the intubation. Okay, and the suboptimal environment, as I have already told you, there will be people. This is not an optimal environment. There is a panic situation in ICU. So how will you proceed in ICU? So for that, you have to be very confident in securing the airway. And the more you practice, more you see the cases, more you work on that, you'll have more skills, and you'll be more confident, and you will be able to be more productive. So let's go for the next slide. So as I have already told you how these ICU patients are, they're different from the patients going for the surgery or anesthesia. So there will be Mm, yeah. So there will be patients with progressive illness requiring rapid intubation. So in that case,
Doctor?
okay, there will be increased risk of profound hypotension. There will be hypotension. There will be cardiac arrest, anesthetic induction, or maybe anesthetic. Hello?
Yes, you're now audible, doctor. There was a split second you're not audible. Now you're audible.
Okay, 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 okay.
You can also switch on your camera, doctor. The camera is off actually.
Oh, camera is off. Okay, now is it on right now? Okay.
Yes,
Can you
yes.
see me now? Yeah. Yeah, so there will be increased risk of profound hypotension and cardiac arrest, and maybe the patient will be anesthetic agent on anesthetic agent. Maybe after surgery, just after surgery, patient has come to you, and you'll have to see that patient is on anesthetic agent. So you have to the patient definitely if the coming from OT, he will be already intubated. But suppose if patient has taken some anesthetic agent and he is not uh, come back to the he is not reversed, reversal is given but he is not reversed, and sometimes what they take out the tube and send to the ICU, and patient doesn't reverse after anesthesia. So in that scenario you'll have to be in panic situation, you'll be in panic situation. So if the patient is on a full abdomen, there's a chance of developing aspiration. There are some diseases like pancreatitis or drug induced, like narcotic patient or morphine, he might have taken narcotic. So there will be delayed gastric emptying. In that case, there are chances of developing aspiration. So, and there are another scenario like injury that makes what makes your intubation difficult in ICU. So sometimes patient come with a head injury, facial injury, maxillofacial trauma, okay, cervical injury. So in cervical injury, what problem you'll face? You'll face the positioning of the patient will be difficult to maintain that sniff position. I'll tell you later what is the sniffing position. Sniffing position, to maintain the sniffing position in it will be a challenging job to do with a patient with cervical injury. So that's another challenge during intubation. So you just have to know these challenges, what comes across to you in working in ICU. There will be limited equipments. There will be less experienced operator assistance, lack of capnography. Capnography that measures the PTC, ETCO2. I mean, endotracheal CO2 value. That CO2 has to be between 35 to 45 mH. Okay. So that if that 35 to 45, that means it is on position, and it's in a it's patent, it's in a lungs. Okay. And there will be limited access to the patient because there will be bed, and that mostly be with a wall side, and it will be very difficult to you to stand there and intubate the patient. You'll have to be very adjusting, and during that, and patient gives a very less time or no time for you to work in ICU. And even waking up the patient is not an option because he might have gone a low GCS or might have been in a anesthetic agents. Can you go to the next slide? Okay, see, all these things I have already discussed. They're like why ICU patients are different. There will be progressive illness requiring rapid intubation, including there will be reduced time of preparation. So all of this I have already mentioned. Hypoxemia, despite of pre-oxygenation, despite of giving a lot of oxygenation, there will be hypoxemia. Okay, can you go to the next slide? So there is a complication in intubation in ICU. So this study has been published in 1995. So even if the intubation is supervised by senior consultants, okay, suppose we have two, this study has been, it has been done in and published in 1995, 297 supervised intubation.
Doctor, you're mute again.
Esophagus, and there is a huge
Doctor, your voice is not audible. It's not clarity.
and get aspirated. And there was a new infiltrates. There's a sign of pulmonary aspiration on chest X-ray. There was 4% of the cases has developed aspiration pneumonia, despite of supervised intubation. It's not just an intubation people has done randomly. It was a supervised intubation, and out of that, there was a 8 patient has a difficult intubation. 8 patient has gone for a esophageal intubation. There was a 4% of the people having chances of pulmonary aspiration of aspiration pneumonia. Hello. Hello. Can you hear me? All of you can. Am I audible?
You're audible, doctor. You're audible. You're audible. Thank you. You
Okay.
can.
Okay. 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 So yeah, and even death occurred during the procedure or within the 30 minutes of intubation was 3%. It's a very high. So 5 out of 7 patients dying had systemic hypertension, and 4 patients already on vasopressor. Yeah, nice to see. Okay, so see, this is how intubation has to be very critical in ICU, and you have to know the all the consequences. Okay, so in ICU or you have seen the complication. Okay, so we can go to the next slide. So, see, this is another study by British Journal of Anesthesia. It has been published in 2011. As you can say, there's a difficult intubation. There was 12 difficult intubation in a Jabber study. There's a Mayo Clinic gives another study, and in the Ball study in 2011, it has given another study. So all of them have the same thing, like the patient is having difficult intubation, hypoxia, patient developing hypertension, aspiration, and cardiac arrest. Okay. We will go to the next slide. We are not going to this data and all that, because we know already there are chances of we have a grave circumstances if you fail to intubate or fail to oxygenate the patient. So this is a major complication of airway management in which was done audit in UK, and there was a less than 20% of the patient airway event in ICU out of 184 patient. Hello.
Sure.
Yeah, Dr. Ashwarya, you want to say something? Hello?
You
Yeah,
can
can
speak,
you?
doctor. I think there was a glitch. They have muted, right? Dr. Aishwarya was muted.
Okay. So there was a less than 20% of the patient airway event occurred in ICU. Okay, go for the previous slide. She wants to see something. Yeah. This one?
Dr. Aishwarya, sorry to interrupt. You can ask this question at the end of the session. We will be able to show you this, and you can, if you want, you can ask these questions.
Yeah.
Take
We
the
can
slide at the
proceed
last.
now. We'll be proceeding now, and in the end, we'll having Q&A session, and where you can raise your queries and all that, and we can go back to the cases and back to the slides. Yeah,
Perfect. Perfect.
let's go. Yeah.
Please, no, sorry. Thank you. Thank you.
No, it's okay. It's okay. So out of that 184 patients, 34 patients has even gone in ICU for airway events, and 50% of the death occurs in ICU, and 60% of the event in ICU led death or the brain damage. It has occurred, compared with the 14% of anesthesia given in anesthesia. Okay, so the event in ICU and emergency department is more likely due to be during general anesthesia, and it occurs in out of hours, like in a night shifts, and all the people are working in night shifts. So there will be less people around you for helping you. So there will be very difficult to manage the patient in ICU, and other than operation theater room, it will be very easy for you will find all optimal situation in operation theater, and there will be less optimal situation in critical care and ICU department. So it will be very difficult for you to intubate the patient in ICU. So there are the capnography. Capnography is a very important device which has to be added in ICU. Despite of all that, we are not being able to provide that in most of the ICUs, but it's there in our ICU. In very advanced ICU, the capnography is there. But in OT, you will find capnography where you can assess the endotracheal intubation is patent or not, just by knowing the number between 35 to 45. If it is between 35 to 45, that means the airway is patent. Okay, so let's go to the next slide. So this is the another study. It has been seen a rapid sequence intubation, or like how useful the muscle relaxants are during rapid sequence intubation or muscle relaxant, no muscle relaxant intubation. So in case of complication, you will see in rapid sequence intubation. Rapid sequence intubation means if the patient comes to you with a respiratory distress, and you will have to intubate the patient, you'll have to give the sedation first and some paralytic agents to intubate the patient, and to make him calm. And there are certain situations where you are not being able to give muscle relaxants. So in that kind of situation, there are two different scenarios. So in that kind of scenario, which one is more beneficial? So by just comparing these two studies, we can see that the rapid sequence intubation has a better outcome than the no muscle relaxant intubation. Let's go to the next slide. So how will you prepare your patient for airway management? So preparation of the airway management is a key. Okay, is a key to the intubation. We have to prepare for the successful intubation. Okay, so first of all, what we do, you will take a very quick and fast history of the patient, because you don't have much time to think about it, and you will have to act fast. So you will have to take the very quick and very important history of the patient, and you will have to be very decisive at that time. You'll have to make decisions very fast. And then you will have to check the equipments whether are there at that point or not. Crash cart is ready, oxygen source are ready or not, properly working suction, your suction tube is properly working or not, your crash cart is ready or not, monitors, drugs which are required to sedate the patient, so is it there or not. Laryngoscope is a very important device Without that, you will not be able to intubate the patient. And there will be sometime you will just put that laryngoscope in the mouth of the patient, you will find batti gul ho gaya. There is no light, and you are not being able to visualize anything. So before that, these things happens, you have to make it very, clear about all these things that in place. You have a battery in your laryngoscope, your light is must be functioning very well. So this has to happen. Okay. Next, go to the left side. Next slide. Yeah, it often happens. Yeah, in Indian hospital, in our scenario, I'm not degrading Indian hospitals, but it happens here. So I'm also facing this problem many a times. Um, Sometimes we get very irritated. What to do? This is how we have to work in here in with this limited devices. So now we have to remember, even if this kind of situation arises, you have to remember one thing, that the failure to ventilate, that kills the patient, not the failure to intubate. So if you are not being able to intubate the patient, don't worry, don't panic. Just do the ambu bag, just proper ventilate the patient properly. Oxygenation should go, just give a full oxygenation, just give a proper mouth fitting mask, hold it by EC clamp. You all are aware of EC clamp, how you hold your neck, head tilt, chin lift, you know. So if you do the head tilt and chin lift, there'll be airway opens up, and when you put the mask, the maximum air goes inside the lung. So with that maneuver, we fit the mask to the mouth and give the mechanical ventilation by ambu bag. So we have to be assured that we have to ventilate the patient properly, and we have to check the ensure the adequate oxygenation all the time. So you always remember, it's not failure to intubate, but it's failure to ventilate the patient that kills. Okay. Let's go to the next slide. So what are the initial assessment, like after intubation, during the intubation, what are the initial assessment you will do? So in the ICU patient, they have a significantly, they'll have a reduced reserve oxygen. Okay. So oxygen reserve will be, patient will be already hypoxemic. So there will be oxygen reserve will be very low. So you have to act very fast. Okay. Otherwise, patient will departure. And you have to act very fast. And after that, you have to check the airway patency. Is it in a way, I mean, in a right place? Is it on trachea or is it in a esophagus? If it is trachea, then it's good. But if it is in a esophagus, it won't be ventilated. The patient will not be ventilated, and all the air goes to the stomach, and you will have a very grave circumstances after that. Patient might get aspirated, and there will be chances of developing aspiration pneumonia. And patient might die also of choking that food content into the airway. I have seen many of our patients dying during intubation. Why? Because they have put the tube in a esophagus. And then we assure just by listening the breath sound with a stethoscope, and we'll see the chest rise. And as I have told you, we open the airway by triple maneuver. Triple maneuver is a head tilt, chin lift, and jaw up thrust. You will up thrust the jaw with the EC clamp. We put the EC clamp. We'll put the mask with a C like this, and there will be E. These three fingers will be E. We'll hold the jaw like that, and we'll fit that C clamp with the mask, and so that it gets fit to the mouth tightly, and we can ventilate the patient properly. And see the after that, once you do that, you have to check the oximeter and the monitor. You'll have to see that even the breathing improves after that or not. Okay. And after that, you can use the oro or nasotracheal airway if the patient bites. if the patient, sometimes you'll see the patient is biting, getting conscious and started biting that tube, and there'll be another obstruction. To prevent that, you can put that airway on a oral, in an oral cavity. Okay. And before intubation, if the patient is not being intubated, you are not being able to intubate the patient. Even during that situation, if you have given the anesthesia and there is chances of having the tongue fall, and tongue fall another put the obstruction to the airway. In that scenario, you can put the oro or nasotracheal airways so that the airway remains patent. And then you can bag mask the patient, and you can do the bag mask ventilation to the patient just to prevent the hypoxemia, because it's not the failure to intubate, it's the failure to ventilate and oxygenate that kills the patient. You always have to remember this thing, then you will not lose the patient. Wherever you are working in ICU or even in a ward, if the patient collapses. Next, go to the next slide. Next slide. So as I've told you, there are many of tests that are available. Like she has told me in the beginning itself, like one of our doctor or they have told participant, they have told me, she has told me about ABG, arterial blood gas. Yeah, we'll go for that. But if even if that is not available to you, there is a certain hospital or in a ward, patient suddenly collapses and you don't have ABG to do, what do you do? So you, in that case, during intubation, you will have to see certain things. You'll have to see certain things. What are these certain things? These are the length of upper incisor. Okay, you have to see the upper incisor. How is it big or small? So if it is big, upper incisor is bigger, longer. So it's going to be the difficult, very difficult for you to put the even the laryngoscope. The mouth will not open properly. And if the mouth will not open properly, how will you able to assess the trachea? I mean, how will we able to go for the tracheal intubation? So another case will be there will be mandibular space compliance. So there will be small, stiff, or indurated or occupied mass. There will be some mass. There will be some tongue mass. Maybe cancer patient. Okay, CA tongue or oral cavity comes to you, and there will be very limited air opening, mouth opening. So it will be very difficult. So these are the condition where intubation is very difficult. I'm telling you that these are the conditions where intubation is very difficult. So you'll have to know these conditions. If the patient is coming with this kind of situation and you are not being able to intubate, first call for help and keep on oxygenating and ventilating the patient. And these conditions are like that. So another problem you'll face in the patient with a thyromental distance. Thyromental distance. This is the thyromental. This is the thyroid cartilage, and this is your mandible. And this distance has to be 3 finger. This 3 finger, minimum 3 finger. If it is less than 3 finger, there will be shortening and there will be difficult intubation. You won't be able to visualize that trachea very well. Okay, and 3 fingers means almost 6 centimeter. So there's another class we'll talk on the next slide. This is Malampati class. If it is more than 2, I mean 3 or 4, if it is more, 3 and 4, then it is going to be a difficult intubation. If your inter-incisor distance, there's a 2 incisor we have, upper and lower. If the inter-incisor distance is less than 2 fingers, that is 3 centimeter. If it is less than 2 fingers, if you're not being able to introduce your 2 fingers in that patient's mouth, then that means it is going to be very difficult intubation. And if there is an overbite is a maxillary incisor is overriding your mandibular incisor, that the lower incisor is overriding your upper incisor. In that situation also intubation is very difficult. And in a patient with a very having any history of difficult intubation, probably having the same problem coming to you. I mean, he will come with the same problem. Okay. Let's go to the next slide. So these are the assessment which you look in a 60 seconds examination. That's I made as this lemon synonym as a lemon. You can remember it. L for looking for an external difficulty. Okay, if you're looking for an external difficulty, patient like incisor and all that, like patient is obese, having thyromental distance is low, patient have short neck. Okay, so these are the external difficulties. Then evaluate using 3-3-2 rule. 3-3-2 rules means 3 fingers fit in the mouth, 3 finger in the mentum and hyoid cartilage, 2 fingers from the mental mandible to the top of the thyroid cartilage. Okay, this 3-3-2 rules you have to remember, like I have told you in the last slide. And Malampati score 1 or 2. If it is 1 or 2, then it's easy. The intubation is easy. If it is 3 or 4, the intubation is very difficult. And if there is any obstruction, and how about the neck mobility? So you have to assess these 5 things before going for the intubation, and then you will have a proper idea. So how your intubation is going to be, how your airway management is going to be. Is it going to be little easier or it's going to be very difficult? Okay. So if it is difficult, what you'll do, you will keep on oxygenating the patient, keep on ventilating the patient, and you will shout for help. Let's go to the next slide. So as I have told you about the Malampati scale. So these are the Malampati scale. Like there are 4 classes of Malampati scale. In class 1, there will be soft palate. You will be able to visualize soft palate, uvula, fauces, and the pillars. The fauces and the pillars will be visible. So there will be no difficulty. Even in class 2, Malampati score, you will be able to see the soft palate, uvula, and fauces also you can see that, but pillars are not visible here. You can see the pillars are not visible. So there also will be no difficulty. But if the only soft palate and the base of uvula visible, as you can see in the class 3, only soft palate you can see there, you cannot see the hard palate properly, and only the base of uvula you can see. So there will be moderate difficulty in intubation. When you put the laryngoscope, you will have these 4 pictures coming to you, a patient requiring intubation. And seeing these 4 pictures, you have to identify the patient whether it's going to be difficult intubation or it's going to be the easy one. So in class 4, only this hard palate only visible. Only the hard palate visible. You won't be able to see that any of the structure. Okay, let's go to the next slide. So there are some Mokacha score. There is a Mokacha score, we call it, and in that Mokacha score, we have given a points to certain factors, and these factors are, if your Malampati score is up to 3 or 4, so we'll give 5 points. And if it's a patient with obstructive sleep apnea, so we'll give 2 points. If a patient with reduced mobility of C spine, like cervical injury or head injury or like that patient coming to you, so then we'll give 1 point. And if there is a limited mouth opening, okay, less than 3 centimeter, it's not more than 3 centimeters, less than 3 centimeter, so we'll give again 1 point. Okay, so there are factors related to pathological coma. Sometimes patient come with a low GCS, we give 1 point again. Low GCS means below 8. Okay, and if the patients with a severe hypoxemia, severe, because there will be less reserve oxygen, you will get less time to intubate the patient because the reserve oxygen is very low. The patient will collapse faster than other patients with a low oxygen reserve. So we'll give 1 point for that. And there are factors related to operators like non-anesthesiologist. If you are not an anesthesiologist, we carry 1 point. Even I carry 1 point because I am not an anesthesiologist. Uh, being a physician, yeah, but I'm quite experienced, so I don't have to worry about that. So yeah, so the point more than two is a difficult intubation. Out of these points, if it is more than two, then it is difficult intubation. Let's go to the next slide. So what are the equipments you require during intubation, endotracheal intubation? So for airway, you need oral airways. As I've told you, if patient is having continuous tongue fall, you have and you are not being able to ventilate the patient with bag mask ventilation, and patient is having low GCS and tongue is falling continuously, you will have to put the oral airway. And then what you need for oxygenation and ventilation? Oxygen source. Definitely you need an oxygen source, be it from the hospital oxygen supply, or be it you can have additional cylinders around you full. Um, and there has to be mask with a various size according to the patient's face size. Just seeing the oral cavity size and the face size, you have to select the mask according to that. And there has to be manual resuscitator like the ambu bag and bag mask ventilation for that. And what you need for during endotracheal tube, the tube has to be between 7 to 9 mm of endotracheal tube. There has to be a malleable stellate. We cannot bougie. If you find difficult to find introduce the tube itself, then what you have to do, you have to put the bougie first to the airway, and then you have to railroad that bougie and put that tube with that. Just as sometimes patient want. Yeah, exactly. So you don't have to put, very forcefully. You have to put it a very gentle way. You have to put that. Sometimes we also some doctors recommend jelly. I don't recommend usually because there is enough saliva there. It doesn't require local anesthesia because patient is already sedated and paralyzed. So let's not put anything additional into that. This is what I believe. But few people they put lubes on the tip of that ET tube. You need syringe to inflate the cuff. Okay. Yeah, KY jelly just to just to lubricate that tube, and you need some adhesive tape to fix that tube, and you need to check the ventilator or from advance. You need to check the ventilator ready all the time. Whenever you are trying to intubate the patient, you will have to put the patient in a ventilator. So you have to be sure that your ventilator is already working. Okay. So once what happened? There's an ICU. A patient came to the ICU, and the ventilator. There was some problem with the ventilator, and they have not checked the ventilator by their department. So biomedical department, they have not checked the ventilator whether it's working or not. So after intubating the patient, we fixed that patient with that ventilator, and ventilator was not working. In that scenario, yeah, the tidal volume, there are various things in ventilator. We'll have a different another chapter, and that we will not be able to concise that chapter in a one class. The ventilator is a huge chapter. We'll go to that also. Okay. So whether the patient is being ventilated or not, we have to check the ventilator. Okay. So in our scenario, that ventilator was not working. So what we had to do, we had to, put the ambu bag, and we have to keep on doing that ourselves only until the ventilator was ready. So yeah, not ambulance. Yeah. Let's go to the next slide. Okay, so these are the checklists before endotracheal intubation. What are the checklists that we have to see in a patient? What are the checklists? Before that, we have checked outside in a hospital. I mean, around us, what our environment should be, what devices and equipments we must have to intubate the patient. But now it's a checklist for the patient, how your patient has to be, and for the smooth intubation. So patient has to be fasting, but in ICU, it's not always necessary the patient will come with a fasting. Sometimes patient with a pancreatitis or sometimes patient with a low GCS will come to you, and he will have a full abdomen and he'll be vomiting at the same time, and you'll have to intubate at the same time. So for that, you'll have to keep your suction device ready, so that you'll do the suction for the properly suction to the oral cavity and the airway. And intra-arterial pressure monitoring is preferable. If you can do the intra-arterial pressure monitoring device in your ICU, you will have the real-time blood pressure monitoring, and it will be easier for you to give the sedation, and at the same time, if vasopressor needed, so you'll have to have a vasopressor in hand to treat the hypotension if patient develops. And long-term sedation need to be prepared, because the patient has to keep on a ventilator, so you'll have to have a long-term sedation prepared, okay, ready. And availability of endotracheal tube with a subglottic suction, as I have told you earlier only, you need a properly suction device, so that you need to clear the secretions and during the intubation. Let's go to the next slide. So these are the emergency induction checklist. So how will you prepare the patient? How will you prepare the equipments? How will you prepare the team and prepare for the difficulties? Need to discuss for the selecting sedative agents smooth. Yeah. We'll go for that. We have that in our next slide. Few couple of slides. We'll discuss about that. The sedative agents also. So now we go one by one. So how will you prepare the patient, and how will you prepare the equipments, and how what are the it's needed in for the preparing the team, and how to prepare for the difficulties, if even after having all these things ready, if you are not being able to secure the airway, then how you are going to prepare. So we prepare the patient by pre-oxygenation. The ETO2 has to be more than 90%. And consider for the CPAP. Continuous CPAP, it's a mode in a ventilation. Okay? So if you are not being able to if you are not being able to ventilate properly, so you have to put the patient with a mask and put the CPAP on a ventilation, and the patient will be ventilated. Nowadays we don't have to go for a continuous bag mask ventilation. We can keep the patient with a CPAP mode in a ventilator, and we have to check the ETO2 has to be more than 90%, the oxygen saturation of endotracheal device. So we have to say the position. Position has to be patient. Few people consider sitting up position, but I consider that uh, patient with a sniff position, sniff maneuver. Okay, we will discuss it in our next slide. How we will have to how we keep the patient in a sniff position. Okay, and how will you prepare for the equipments? So you need capnography, saturation probe, ECG, blood pressure monitoring. Okay, so this has to be there. Okay, and you have to check the equipments are ready. There are another equipments are self-limiting bag, self-inflating bags, like it has to inflate itself and deflate itself. Okay, when you deflate it, it has to inflate itself. You have seen the ambu bags, right? It is like that. So you don't have to work hard for inflating it. There will be less time. Patient will not give much time to the in a ICU. So it has to be self-inflating, so that you just have to work for the deflating the bag. And there is a working of suction tube are working or not. You have to have endotracheal tube, two tubes at least. You have to have, suppose if the tube bulb is not adequate, it's not inflated, so you have to change the tube. If the size is not adequate, according to the airway size, you have to have two different size of, at least two different size of tubes, two laryngoscope, because yeah, in ICU or wherever you work, there are chances of, if the one laryngoscope is not working, the light is not working, you have to have at least two laryngoscopes. There have to have a bougie means that stilate, malleable stilate, which you put inside the trachea if you're not being able to put that tube. Okay, there should have you should have a supraglottic airway device. Okay, supraglottic airway device. What is supraglottic airway device? These are the airway device which you are not, if you fail to intubate the patient, then we go for a supraglottic airway device that just gets stuck to that glottis and get above the glottic area, and it's adequate to supply the oxygenation to the lungs. Okay, after putting supraglottic devices, nowadays LMA is the most appropriate laryngeo mask. Devices are nowadays, airway devices are now in use, LMA in a supraglottic devices. So next, and all the drugs what you required during intubation, be it sedation or muscle relaxants. Okay, and you have to prepare for the team, allocate the roles. Eye gel mask, yeah, eye gel mask, yeah. These are also supraglottic devices of eye gel and LMA. These are nowadays it's a very frequently used. And now how you prepare the team? You'll have a couple of people around you, so you'll have to appoint them. Some has to be a team leader. The one he is standing behind the patient and the head side has to be the team leader. He will tell you, he'll tell each or everyone, he'll appoint uh, the role to that people around you. So there will be first intubator. Who will intubate first? The most experienced person has to be the first intubator. Second intubator will be, he also has to be experienced also, and maybe the more experienced than the first one, because if he fails to intubate, he will be the one to take over. Okay, so there will be second intubator also, and both of them has to be experienced. So sometimes we need required pressure, Selic maneuver. We call it Selic maneuver. We have to press here in a cricoid cartilage, and when you press the cricoid cartilage, your airway are quite visible. Better, you can see quite better than usually you see that. If you put the cricoid pressure, the airway becomes more visible, and it will be easier for you to intubate the patient. And who will be giving the drugs to the patient, and after giving the drugs, he has to shout loudly that this medicine has been given, sedation has been given, flushed, done, muscle relaxant given. So this, you have to appoint role to each and every staff. There has to have one rescue airway. If you fail to intubate, you have to have that rescue airway. You have to have the person ready with a bag mask ventilation. He has to be ready with a cylinder with a full oxygen pressure. Yeah. So all these things has to be there in, well prepared, ready in your hand. So And the another one, there's a one person also has to be there to shout. Suppose again you are not, because you will have very less time, maybe 2 minutes, 3 minutes. 3 minutes of a hypoxia can lead to the brain damage, hypoxic brain injury, you know. So we don't want this to happen. So we have to act very fast, and we have to appoint each and everyone for this kind of situation. If you are not being able to intubate, then call for help, call for more people, call for more experienced people. We might need cricothyrotomy. There needs a person who is skilled in cricothyrotomy, or even if cricothyrotomy is not possible, then you might need a surgical, okay, tracheostomy you might need. So you have to call for help. If you're there has to be a person for that, appointed for that. And so now it comes again for it. If you get prepared for the difficulties. So these are the difficulties I have, as I have already told you. So you fail to intubate, you need to shout for help. So what are the plan? There are four plans in a difficult intubation. One is a rapid sequence intubation, plan A, where you sedate and paralyze the patient, and then you do the intubation. Plan B is if you fail to intubate the patient, then bag mask ventilation. You keep on doing the bag mask ventilation. As I have told you, that it's not fail to intubation, it's fail to oxygenation that kills a patient. You always remember this point because this is very important. Okay, so the next plan is plan C, is a ProSeal or LMA, that is supraglottic devices which are available in the market right now these days. So we can use them if we fail to next to ventilation, bag mask ventilation. And then plan D is front of your neck, I mean cricothyrotomy. Okay, and where is the next relevant equipments, including alternative airway, do not start until it's available. Okay, so all these equipments, if it's during intubation it fails, so even if there is a not alternative airway available, so do not start it. You just keep on ventilating the patient. Okay, until unless the expert comes to you and start helping you, you have to keep on patient on ventilation and oxygenation. And just look for the any specific complication which can be anticipated. Let's go to the next slide. So right after intubation, so whether the tube is in position or not. No, this is for the positioning of the patient. Sorry, I'm getting. Yeah, this is how we position the patient prior to intubation. So we have to lock the bed before doing the intubation, because once you have kept the patient on the bed and the patient start moving around, the bed start moving around, it will be very difficult to you. Then it's always required to lock the bed and remove the headboard. I mean the pillow should be removed. Okay, to keep that patient in sniffing position. Okay, this gives the sniffing position. In the next slide we will give with a picture what is the sniffing position. Okay, in case of cervical spine injury, the head need to be positioned neutrally. You cannot extend the neck. You can just only open the, you can only chin lift. Okay, but you cannot extend the neck. Okay, and you have to keep that Philadelphia collar, so that neck stability has to be maintained. Cervical collar has to be there. For next slide, just to maintain the cervical stability. See, this is the sniffing position. What is the sniffing position? There will be three axes: laryngeal axis, pharyngeal axis, and oral axis, as you can see that. Okay, so in a pharyngeal axis and laryngeal axis, the visibility of airway is more. Okay, so the classical, this is the classical sniffing position. It has three axes. One is oral, as I've told you, and pharyngeal axis and laryngeal axis. This alignment, it facilitates the glottic view. So you will be able to visualize the airway properly with these three axes. And as you can see, in a pharyngeal and laryngeal axes, it will be easier for you to see that airway properly. Okay, let's go to the next slide. Now this is the sniffing position. You just keep that screenshot with you and keep it with you while before intubating the patient. You should maintain this position to the patient. So before intubation, you need to pre-oxygenate the patient with a back mask using the face mask. Up to the 15 liter per minute, that gives them around 100% of oxygenation. Or maybe with a bamboo bag or reservoir bag, you can put it. Okay, and that also allow ventilation if the patient is breathing spontaneously. If patient is not ventilating spontaneously, then you will have to go for the bamboo bag or an IV support. CPAP, go for the CPAP. Okay, so any mask ventilation ability. So how will you assess? We have an acronym for that. This is called bones. So the patient with a patient beard like me will have a difficult intubation because putting the mask. Hello, am I audible right now? Am I audible? Give me a
Yes,
thumbs
doctor,
up.
you're audible. You're audible.
Okay. See, so we have this to assess the mask ventilation ability, whether we can ventilate the patient with a mask properly or not. We have an acronym. It's called bones. The patient with a beard like me, the huge big beards, will have a difficult ventilation by mask. A patient, obese patient, a patient has no teeth, the older patient, patient with the sleep apnea. These are the people, there are even the bag mask ventilation is difficult. Let's go to the next slide. So in that case, what we'll do? What we'll do in that case? If you are not being able to ventilate the patient with bag mask, we have discussed earlier. Anyone? I want it from hear it from you guys. We'll go for a subglottic device, supraglottic device. Okay, like LMAs, iGel, and all that. Let's go to the next slide, please. So how will you pre-oxygenate the patient? So sometimes we, as I've told you, non-invasive positive pressure ventilation by CPAP, support ventilation. These things started in COVID time very frequently because intubation during COVID, I have seen a very less people coming out of the intubation, and this non-invasive ventilation has worked in very well in during COVID times. Patient with even in the severe COVID patient with a prone position and non-invasive ventilation has come out. So it has given a better result than patient has gone for the intubation. So it's not always a patient who dies with a, if you're not being able to intubate. If you have failed to ventilate the patient, that kills the patient. Okay, you always remember this. So use of NIV, non-invasive ventilation, to pre-oxygenate the patient before intubation. Why you need to pre-oxygenate the patient? Just to increase the reserve oxygen to the patient, so that it will give sufficient time to intubate the patient, and patient will not fall rapidly. So prior to intubating the patient, you will have to have pre-oxygenation of at least 10 to 15 minutes. If you can do it adequately, then a patient can give you more of a time to intubate. Okay, this increase apnea, this will increase the apnea time and reserve, as I have told you. And attach the monitors, secure the IV accesses. Maybe you require patient, suppose during intubation patient collapses, then it might need vasopressors, BP falls down, you need vasopressors for that. And if patient goes bradycardia, you need atropine. And even patient could go on cardiac arrest, CPR might need it. You might need adrenaline during that time. So IV access has to be there before intubating the patient. You have to make sure all these things are already done before intubation. And also make sure the help is available. The anesthesiologist is available maybe in OT, or maybe in wherever in your hospital. You have to find, you have to shout for help. You have to have that reserve already done. So let's go to the next slide, please. So now coming to the drug, some of you were asking about the drugs. What are the drugs we are requiring during the intubation? So during endotracheal intubation, etomidate, nowadays it has come, etomidate, most preferable drug. The dose is, you can take the screenshot of this slide, because I'm not going to tell you the doses because it's already written here, and you can have it. But I can tell you that here, like, what are the consequences of these drugs if you give etomidate. You can, it's the most commonly used, and it's a cardiovascularly stable drug. Patient with a cardiovascular shock, patient coming with MI, or patient in cardiovascular shock, cardiogenic shock. So it is most preferable drug for that. And but it causes adrenal suppression. So if a patient, you have to have that adrenaline ready for that if patient goes for the adrenal suppression. Or you can give the midazolam, but it is very convenient to use, but it further it goes in a favor of, it causes respiratory depression. So if you fail to intubate the patient again, and even it falls down the BP also. Okay. And the next one is fentanyl. It act fast and it affects is good. So fentanyl effect, I usually prefer fentanyl and succinylcholine if there is no head injury, if there is no raised intracranial pressure. But there are a few places that they use ketamine. Ketamine also most preferably used, but there is a chance if patient come with a head injury and raised intracranial pressure or high BP, so ketamine you cannot use. For that, fentanyl is good enough to work. And propofol, it also causes uh, common form worsen hypertension. Yeah, that's why I'm telling you the fentanyl is more preferable than midazolam. Because midazolam is more associated, midazolam, propofol, and these are the drugs which are more, it causes, they are prone for a low blood pressure. It causes low blood pressure. So you have to be ready for this, and you have to be ready with the fluid management. You have to be ready with the vasopressors and all that. But if the patient is already in vasopressor with a low blood pressure, so you will have to be very, selective. In that case, ketamine works very good when the patient's having low blood pressure. But if there is a raised ICP, you cannot give ketamine. Thiopenton. This is more preferable in a patients with neurosurgical patients, the patient with the neuro problems. And succinylcholine. Succinylcholine is basically it, paralyze neuromuscular relaxant kind of thing. So it depolarizes the neuromuscular bundle. So its action is very rapid and often, so it's very oftenly used for rapid sequencing intubation. But you have to be very careful. Even in raised ICP, we should avoid succinylcholine. Then we have to go for other muscle relaxants like rocuronium. Okay. at tracuranium, rocuranium. Yeah, at tracuranium, exactly. Let's go to the next slide. So what is the rapid sequencing intubation? You might have hearing this word rapid sequence intubation, rapid sequence intubation. So this is the rapid sequence intubation. It's performed after pre-oxygenation and preloading. Preloading means you have to give adequate fluid, you have to get adequate oxygenation so that the patient will have reserve oxygenation. Rapid administration of the drugs, the weight based, as I've given all the drugs dose in a per kg. So you have to calculate according to the weight of the patient. Okay, the dose has to be calculated according to the weight of the patient, ketomidate or ketamine. And then we give rapid acting neuromuscular blocking agents like succinyl choline or rocuranium, as I've told you. Then apply for the cricoid pressure, that is Selick maneuver. So to visualize the airway required pressure, it helps to visualize the airway. Okay, and rapid tracheal intubation without ventilating the patient. So during that time, the intubation, you will have no chance of ventilating the patient because you will take off the mask and you will be putting that laryngoscope into the mouth and you will be visualizing and struggling to see that airway, and you will have a very less time to put that ET tube to the trachea. And to increase that reserve time, you will have to be ready with the pre-oxygenation, pre-loading, and all these things ready beforehand to avoid any serious complication. Let's go to the next slide. So after this, we'll have to be confirmed with the ET tube. Is it in place or not with EtCO2 with a capnography? We must have in our ICU, but unfortunately, it's not available in most of the ICUs. So EtCO2 has to be there, and it should give the reading of 35 to 45 of mercury, and any link of participating certificate. Okay, we'll discuss it on later. Let's go to the next slide. Let's go to the next slide. Yeah, please. So these are the step of the endotracheal intubation. After endotracheal intubation, we have gone to the during the intubation. Now what we have to see after intubation. First, then we have to auscultate the patient that the tube is in place or not. Where we have to auscultate on the chest while putting the airway. We will put the ambu bag and press it, and with the same time we will auscultating both of the lungs. The air entry has to be adequate, has to be equal on the both sides. We have to fix the tube at the 20 centimeter in female, and for the male it is 22 centimeter, but it varies according according to the size of the neck and the theromental distance, as I have told you. So it varies to the people to people. Okay, so if there is a tube fixed more, it is more inside, it's more than 20, or it has intubation patient, the tube has gone to the right side of the bronchus. It's more commonly goes to the right side because right bronchus, it comes prior to the left one. When you goes inside, the tube goes inside, the right bronchus comes first, and then comes in the carina. There will be the right bronchus has a little superior to the left bronchus. So the tube is more tend to go towards the right lung than the left one. So then you will be hearing the sound, airway entry will be more in the right side, less in the left side. Then what you will have to do, you will have to pull the tube a little up so that we don't go for endobronchial intubation. Okay. And then we'll introduce the orogastric tube. Nowadays, nasogastric tubes are not recommended due to there is a chances of aspiration. So we more of suggest for a orogastric tube after intubation. Let's go to the next slide, please. So what are the steps after tracheal intubation? So far we have gone this, and then after putting the intubation, if you find it, the patient, the tube is patent, it's in a place, equal air entry, adequate air entry. So we initiate the mechanical ventilation. And to work the mechanical ventilation properly, immediate X-ray after that. Yes, we have to see the X-ray, definitely. But by the time once you have checked the airway is in place with this stethoscope, and you assess just by chest rising, and there is another finding you will find there will be mist. You will find the mist in a ET tube, and it's a confirmatory for the um, tracheal intubation, not an esophageal intubation. If you put the esophageal intubation, you will find there will be gastric content coming out, and you have to pull it out as soon as possible if you find it's not in trachea. If it is in esophagus, you have to just take it out and do the suctioning first. Okay, and then give the analgesia and sedation so that your mechanical ventilation work properly, because patient will be fighting, and because it's very painful condition for someone to having something, because once a small thing goes to your airway, you start coughing. So, such a big tube goes to your airway, and people find it very discomfort. So you have to keep the patient sedated, and to keep the patient sedated, and patient has to be sometimes, if you're putting on a mechanical ventilation, has to be paralyzed also, because even there is a tachypnea despite of giving adequate sedation, patient is tachypneic and patient is having labored breathing, you'll have to give the muscle relaxant so that your ventilator works properly. Okay, so and then definitely we'll go for the chest radiograph, chest x-ray, to see that chest the tube is in place or not. Okay, and then go for the check ETT cuff pressure. It has to be below 20 mm of Hg. So if it is more than 20 mm of Hg, then there will be chances of developing tracheomalacia. Okay, so if there is a more pressure around the trachea, there are chances of developing this tracheal tissue after a longer time of period. They will be necrosed and might be having the chances of tracheomalacia. Let's go to the next slide, please. Next slide, please. Yeah. So after anticipated difficult, so with as I have told you previously, how to anticipate the difficult intubation. Once you have anticipated the difficult intubation, what you'll do? Call for an airway expert, someone anesthesiologist available in a hospital. Don't give muscle relaxant if you find there is a difficult intubation. If you give the muscle relaxant, patient will not be able to breathe himself. So anyhow, you will have to put on mechanical ventilation, and without putting endotracheal tube, you will not be able to ventilate the patient properly. So don't give muscle relaxant. If you find the patient before intubation, you will find the patient he has to go for a difficult intubation, don't give muscle relaxant, call for an expert. And by the time, what you do, just keep on ventilating the patient with bag mask ventilation. That's it. Next step is to have a flexible bronchoscopy, and intubation is the first choice. Flexible bronchoscopy to see the airway, visualize the airway. We go for a video laryngoscope. There is a video laryngoscope available nowadays, and it improves the glottic visualization, and to make intubation easier, the video laryngoscope and flexible bronchoscopy is nowadays we are having a great help these days. How is it? It helps. If there is a less of airway, I mean, mouth opening, you are not being able to visualize the glottic area. You have to put that the flexible bronchoscopy that goes to the trachea, even if the not adequate visualization. With the video laryngoscope, you definitely will have a better visualization that what we use a laryngoscope in our scenario. Okay, so the visual laryngoscope, it helps better than this traditional airway. Also need participating certificate. Okay, let's finish it fast, then we'll have a certificate definitely. Yeah, we are trained for the traditional one. Yeah, see, just by having this class will not be sufficient. I'll also give you some videos after the session where you can visualize. But definitely we are also working for the, you know, one-to-one classes. I mean, so that we can practically do these things in a scenario with a mannequins and all that, so that we can see that and do that at the same time. So let's come back to the case now. The case, you remember, as I have mentioned, you are 60-year-old 80 kg diabetic male patient come to your ICU setup with a lower pneumonia, and he has a history of progressive breathlessness with altered mental status for last 6 hours. And on induction of anesthesia with etomidate and suxamethonium, you will find that unable to ventilate and intubate the patient. Now this is another problem. You have given suxamethonium and etomidate also. Patient is sedated and paralyzed. And now you are not being able to intubate the patient. Now how will you manage the patient? Anyone? Any idea? LMA? Definitely LMA. Bag mask? Yeah, bag mask. We have to ventilate the patient. Correct. We have to ventilate and oxygenate the patient somehow. But the thing is that you have already given the etomidate and suxamethonium. The patient is not breathing himself. Spontaneous breathing is lost. And unless you have not intubated the patient, it will be very difficult to ventilate the patient mechanically. Okay. So let's go to the next slide. Let's see. Yeah. There are various of modalities we can use it. But even those things doesn't work. What we'll do? We go for cricothyrotomy. Okay. Let's go to the next slide, please. See, this is the inserting the LMA. How will you insert the LMA? You have to go. We have the video for that. If you can play the video right now, we can see the how we put that LMA.
Playing the video, 1 second.
Yeah.
Just to demonstrate that insertion, if I tilt the head back, I might get an assist. So just to demonstrate that insertion, if I tilt the head back, I might get an assistant to
Is audible? Can you hear the voice?
Yeah.
open the mouth, or even try to do it myself.
Sorry?
Can you little enlarge it? I mean, yeah. That's it.
I push it past the teeth gently, and then I'll push backwards so it goes along the upper palate, the hard palate, and then down the soft palate past the tongue. Again, sitting just above the airway, the trachea, which allows ventilation. Again, as always, I check ventilation. You can see it rise and fall of the chest, and sometimes that's all you need. Other times you'll inflate the cuff and it's already got some zones marked out. Essentially, you want to inflate that cuff and try to create a better seal. So just to demonstrate that insertion, I tilt the head back. I might get an assistant to open the mouth. Or even
Yes, doctor.
Yeah. So let's go back to the slide now. As you have seen, first you have to lubricate the tip, then open the oral cavity with the fingers and insert it and slide it along with the hard palate. Okay, you go along with the hard palate, and finally you position it using your index finger just near the larynx. Okay, and inflate it. So once you inflate it, the LMA device, it comes out slightly, and this indicates that it has been placed successfully. Okay, let's go to the next slide, please. So we going back to the case now. So the expert, the anesthesiologist from OT, he has come to you, and he advised you to put that LMA, and even after putting that LMA, you are not being able to ventilate. As I have told you in the last scenario, like even if putting the LMA, you are not being able to ventilate the patient. Then what you will do? Now tell me, please, any of you, because in you have already changed the. Yes. Yeah, cricothyrotomy. Yeah, I mentioned in the last few slide. Yeah, and the next slide. Come on, let's change. Next slide, please. So this is the cricothyrotomy. So how, where we do the cricothyrotomy? So this red marked area is the place, is a less vascular area. This is cricothyroid membrane. Okay, so we do that incision over there. We'll put incision with the blade and rotate the blade, the incision with the handle, because we want to make it a blunt opening. We are not making it a sharp opening. We just make a incision with a sharp blade and rotate it to make the hole bigger with the handle or the forceps. Okay, or the artery forceps, and then we place that tube, tracheostomy tube or endotracheal tube into that place. Or sometimes we do needle tracheostomy, cricothyrotomy, needle cricothyrotomy, or surgical cricothyrotomy. In surgical cricothyrotomy, you make an incision with a knife, and with a needle cricothyrotomy, you just have to put the needle into that cricothyroid membrane. So this area is relatively avascular area, and there is no major structure present over there. So can you play that video of cricothyrotomy, please?
Yes,
See, as I've all, yeah, just go to the previous slide. Go to the next one, please.
this
Next one, yeah. You don't go for a vertical or even the horizontal. Okay, the vertical is most preferably, but we just have to make a nick. We don't make a big, incision. We don't incise it. Just stab it with the knife, and you have to make it larger with a artery forceps. Some people, because since it's a avascular area, but even if it some people make it a vertical more preferably, but here you can see there is a horizontal incision has been given over here, but yeah, is a vertical. No, it's not for cricothyrotomy, needle cricothyrotomy. No ENT specialist is required. Even a resident working in ICU can do that if it is well trained. So it's very easy, and once you learn it, the position where to do it, it's a life-saving process. All of you must learn this, because in a case of difficult intubation, even LMA fails, this is the gold standard and the last resort for the patient to ventilate or oxygenate. So in surgical cricothyrotomy, you need a stab knife. You had to stab with a knife, and you have to have an artery forceps, an ET tube of 5 mm size, or tracheostomy tube if you have available, then it's well and good. And cricothyrotomy kits nowadays, it's available in the market. The whole everything will be there. You don't have to worry about that. There will be knife, there will be artery forceps, there will be even tube is already there with a procar. And in the needle, needle cricothyrotomy, you need 14 gauge cannula, or you can have a 2 cc syringe to assess whether it is in a trachea or not. And how will you assess? You will put some saline into that 2 cc syringe, 2 ml syringe, and you go to that place with a 14 gauge cannula. And if you see the bubbles are coming out, then it's a confirmatory for that it has been placed in a trachea. Okay. And that 5 mm universal connector, you have to have that, because 5 mm connector will only connect to the T-piece or ambu bag. So you'll have to oxygenate the patient. So for that, you have to have the universal connector for 14 gauge cannula. Okay. So can you please play that cricothyrotomy video? Hello, can you please play the cricothyrotomy video? There is a video for cricothyrotomy.
Playing the video, doctor. Yes.
Yeah, please.
Oh. The last one, right, doctor?
Yeah. The last one.
The cricothyroid membrane is an avascular structure
The sound is not coming.
Doctor, the sound is not coming?
No. The sound is not coming.
structure
Now?
Yeah, now it's coming. Yeah.
thyroid cartilage and the cricoid cartilage in the interior part of the neck. The thyroid cartilage, here illustrated in red, is the Adam's apple, and it's relatively easily palpated. The membrane
Yeah.
is situated right below it, and below this is the cricoid cartilage, here in yellow. There are, of course, many important vascular and anatomical structures in the interior part of the neck, but the use of the cricothyroid membrane for tracheal access is relatively safe. There are also techniques using ultrasound which may further facilitate orientation. The system used in this video is the Melker wide-bore cannula over needle cricothyroidotomy set. If time allows, the front of the neck should be cleaned with an appropriate skin solution and the area prepared as a sterile field, but this should not significantly delay the procedure in an emergency. When the anatomical landmarks have been identified, a cannula is inserted, attached to a small syringe filled with a small amount of saline solution. Careful aspiration when introducing the needle results in bubbles when the tip reaches the trachea. A wire can then be inserted through the needle using the Seldinger technique. Taking care that the needle position is not lost, the wire is introduced and it should glide easily without resistance. The needle is then removed, leaving the wire in situ. At this point, use a scalpel to make a horizontal incision into the cricothyroid membrane along the guide wire. Note that some experts argue that the preferred order is a vertical incision prior to cannulation, but this is the preferred order at our center. The cannula is preloaded over a dilator and the whole assembly is inserted over the guide wire as shown. The wire and the introducer can then be removed. The cuff is now inflated, and while being very careful not to dislodge the cannula, the location is confirmed by using a capnograph and observing the raising of the chest wall during ventilation. A pertinent airway has now been achieved.
Yeah, there is another video, landmark for the cricothyrotomy. You will have to, you just see that video, you will find very easy to identify
To
the
perform a
landmark.
cric. But how do you landmark it? Let me show you. Okay, so I have a little model here for you in order to kind of give you a visual idea. So we have the hyboid bone here, then we have the thyroid cartilage here, and then we have the cricoid rings here. So I have them labeled here, and I think of an acronym called HIT the cric. And that means the hyboid bone, the thyroid cartilage, and the cricoid ring, so the cricoid cartilage. And we're going to cut in between the thyroid cartilage and the cricoid cartilage, so hit the cric. So the idea here, to give you kind of an idea on a person, on a patient, so this guy here, this Adam's apple, that actually is made from the prominence of the thyroid cartilage right here. And so once you find the Adam's apple, that prominence, you know that you are on the thyroid cartilage, and you're just going to continue to palpate down until you find the cricoid cartilage, okay, which is going to be below, and just above that cricoid cartilage is going to be a softer area, which is the membrane that you're going to be cutting through. So that's how you landmark for a cric. You love our short videos and you're worried that you're going to miss some of them? Well, don't worry about that, because we're going to send them straight to your email. All you need to do is
So let's go back to the slide again. Yeah. So this is how we do cricothyrotomy. I think you all have gone through it, and the videos has made it very clear to identify the the site of the incision and how to place it. Now I think all of you might have been very clear. And next time, if you go to your hospital, if you find it, you just go and find that place at least with the patients, and you can find it in yourself also. Like, where is that Adam's apple? Just go 2 centimeters below that. You will find a softer area, and that is your cricoid membrane. And this is where you have to give that incision. Okay, and rest of the process are the same, like that, which have been mentioned in the videos. Let's go to the next slide, please. Please take that, this is the algorithm. Take that. Age limitation for cricothyrotomy. There is no age limitation for cricothyrotomy. It's a life-saving procedure, and if it is required to save the life, it has to be done. It's an emergency situation, so there is no age limitation for the emergency situation. You have to save the patient somehow. And this is the algorithm for the in children. See, even in children, will it be pretty sure? Yeah, we'll share it. We'll share it. We'll talk to that. You can talk to Ifka. She will definitely share it. So in children, there are very less chances of having a difficult airway, because that children, only children comes with a some anomaly, some oral anomaly is there, then only it will be difficult. And in that case, cricothyrotomy, you can do that. You are not the person to do that in that situation. In that situation, you will not find Adam's apple. You will not find the landmarks in the children. So you have to call for a anesthesiologist for that, or you'll have to call for the ENT surgeon for that. So this is the algorithm for the airway management in ICU. So airman, you have to see that this had been published in 2007. And how will you manage the airway in ICU. The patient, you have to find the patient which requires airway management. If it is possible, call for the senior physician for the assistance. And then you see whether patient can be managed invasively or non-invasively. If you can ventilate the patient with bag mask ventilation or NIV support, then it's well and good. NIVP, you can do it. Or if the patient has to manage with the invasive, go for the intubation. So if you go for the intubation, there has to have a yeah, that can be replaced after some time. So there will be have a potential chance of having difficult mechanical ventilation or difficult intubation. Okay, if there is a adequate physiological reserve, and if there is no adequate physiological reserve. If there is no adequate physiological reserve, then patient doesn't give you much time. Go for a direct laryngoscope, okay, and go for a intubation for rapid sequencing, maybe, or non rapid sequencing. Neuromuscular blocking, if you are not being able to give them neuromuscular agents, you have to go for that. You have to select this, okay. And if the patient is respiratory arrest, so go for a intubation. If patient is in a respiratory arrest, you cannot wait for that. If you cannot intubate the patient, use LMA, or even cannot introduce the LMA, go for cricothyrotomy. But you have to remember always, these are the breathing processes. LMA or cricothyrotomy is a breathing process. So that by the time the expert comes to you and do that proper, airway secure with either with a ET tube or tracheostomy tube, till that LMA or cricothyrotomy is just a breathing device, breathing maneuver. So let's go to the next slide. So these are the intubation bundle. Okay. So what is the intubation bundle? It has three components: pre-intubation, during intubation, and post-intubation. So this is the intubation bundle in pre-intubation. What are the pre-intubation bundle? So it has to have two operators. You have to have at least two operators. There is a fluid loading. Patient has to be adequately, you have to give the fluid, but you have to be very careful so that patient is having cardiogenic pulmonary edema or something like that. Okay, so in that case you don't give fluid overload, and you will prepare for a long-term sedation, and has to be pre-oxygenate the patient at least for 3 minutes with NIVP. Okay, and with FiO2 100%, pressure support ventilation 5 to 6, and tidal volume 6 to 8 ml per kg has to have per kg, 6 to 5 ml, and PEEP has to be 5 centimeter of STO. These things we will discuss more in ventilatory support. Maybe you will not be able to understand right now, but these are the things you have to give in a pre-intubation bundle. Patient has to be oxygenated well at least for 3 minutes. Okay, let's go for next slide. Next slide, please. There is one more lacking, I guess, intubation, pre-intubation, and during intubation. There is a during intubation bundle. If the slide is missing, just go. No. Next.
Oh, yes, doctor. Pre-intubation, post.
And post intubation. Go next. Go next. I think no. So I'll tell you. So this is the during intubation. So there will be rapid sequencing induction. This is the same thing which I have told you during the rapid sequencing intubation. That means you have to give the patient sedation and neuromuscular blocking agents like succinylcholine and all that, and sedation with either intermediate or ketamine or fentanyl, whichever is preferable for the according to the condition of the patient. And in case of you'll have also allergic or hyperkalemia and severe acidosis, and acute chronic neuromuscular disease, acute or chronic, or burn patient, more than 48 hours, spinal cord trauma. Okay, so you cannot give succinylcholine in this kind of patients which have allergy, hyperkalemia, severe acidosis. We'll share this. We'll share this slide to you because it's important. And during intubation, there will be Talik maneuver. You have to, uh, do that external pressure to the cricoid cartilage so that you can visualize the glottis properly. Let's go to the post-intubation one. So this was the during intubation, and now the post-intubation was like is to confirm the ETI intubation. Is it there a patent or not? So you have to see ETCO2 35 to 45 mm of Hg. You have to have the capnography for that. You have to be ready with norepinephrine in case of blood pressure, diastolic blood pressure less than 35, and you have to have a long-term sedation so that you can ventilate the patient properly. And you have to have the lung protective ventilation where the low tidal and high PEEP. So tidal volume has to have 6 to 8 ml per kg, and PEEP has to have around 5 centimeter of STA. Okay. And respiratory rate will set around 10 to 20, FiO2 100% in the initial state, and if the patient is maintaining well, slowly we'll decrease the FiO2. We'll have another chapter of oxygenation. For this, we'll discuss all that, how much oxygenation you should give to the patient according to the cases and all that. And you have to maintain the plateau pressure of less than 30 centimeter of STU, because if you don't maintain all this, there will be chances of developing the barotrauma or lung injury, further lung injury. So you have to be very careful after during giving the ventilation to the patient to protect the lung. So this is called lung protective ventilation. Next slide, please. So these are the intubation bundle, how it works. So this study has been shown by American Journal. This is a consecutive, I mean, out of like the previous study which I have told you, out of 244 intubated patient which in an ICU, we have a intubation. There will be. Let's go to the next slide, please. So there will be result. What was the result? So there is a life-threatening complication within 60 minutes if you don't follow the intubation bundle. There was a life-threatening condition developed within 60 minutes, within 1 hour of intubation, if you don't follow that intubation bundle. It has been seen in these studies. And so there was a significant life-threatening complication decrease, around 34%, and other complication around 21% in phase 2. Okay. An implementation of intubation management protocol can reduce the immediate severe life-threatening complications. So with this intubation bundle, it has been proven with this various studies like that it is very safe for the patient, and it reduces the post-intubation complications. So thank you so much. This was all about that. You can see that devices in that here, what equipments which are required for during intubation. So this is the laryngoscope. Okay, we are not giving here a video laryngoscope here, but this is the traditional one which we usually use in ICU. And there's a McGill's forceps, there is a suction tube, there is a ET tube, there is a LMA, and there is a gel, you can say here. Next slide. So this is how we manage the airway in ICU and in our clinical scenario. So if you have any question answer, your all questions are welcome here.
Yes, thank you, doctor. So we will be opening
Thank
up
you so much.
sessions. So
Yeah.
people can write your questions on the chat box. We will read it out to doctor, and doctor will be answering your questions.
Yeah.
Thank you. So I'll stop the screen sharing now. If you want to come on the video and ask question, you are welcome to do that. Or if you can just drop your question on the chat box.
Thank you, Gautam ji.
Yes, the Gautam says excellent presentation. Thank you so much.
Thank you so.
Gangadhari Diana is
Thank you.
thank you. Dr. Twinkle is asking how frequently to ET sections to prevent tracheal trauma DIR. Please, you take it.
No, can I get the question again?
Yeah, yeah. So it is in the chat box if you can see. How frequently to ET sections to prevent tracheal trauma directory, I guess. So Kirti says, nice presentation, sir. Thank you, Kirti. Rohini Vijay says, thank you, sir. Thank you, Rohini. Dr. Raju Sarkar says, excellent, sir. Thank you, Dr. Raju. Dr. Arif says, awesome presentation. Thank you, Dr. Arif. Dr. Rohit Kakkar says, a very informative webinar, sir. Thank you for conducting. Thank you so much, Dr. Rohit. We'll be conducting more such webinars. Please do follow our social medias. You'll get to know that. Dr. Kunal, can you hear me? Hello? Doctor? I think there is a slight technical glitch. Now, doctors, let me also tell you, Dr. Kunal has been working from 36 hours continuously in the ET. There was an emergency visit. He was supposed to be on leave, but there was a unforeseen situation where Dr. Kunal's attention was needed, so he was called back to a hospital. Okay, doctor is asking me to unmute. Doctor, 1 second. Doctor, now try to unmute yourself.
Yeah.
Yeah.
Now, please share the video. I mean, even the video is barred from your side.
Yeah, yeah. You can now. You can now. You can now.
Okay. Yeah.
Yeah. So, doctor, I was
Yeah.
saying that doctor has been doing continuous duty from the last 36 hours. He was actually supposed to be on leave today, but like I said earlier, due to some unforeseen situation, he
Yeah.
has to come back. His attention was needed in the ICU. As we speak now, doctor is sitting in the ICU, and he was actually he was told us that let us not cancel the session since it was already put out there from last 15-20 days. Let us not cancel the session. I'll make myself free and I make sure the session goes well. And thank you so much, doctor. Thank you for making that effort towards to our candidates. Doctor, there are some
Thank you.
questions flowing in.
Yeah, I'm just seeing that how
Yeah.
frequently to ET suction to prevent the tracheal trauma, sir. See, tracheal suction, ET suction has to be done whenever there is a chances of secretion is there of, or there is chances of blockage. You see that a patient is not maintaining saturation despite of giving full oxygen supply, and the patient was maintaining, and all of a sudden patient was not maintaining. That means there is some kind of secretion over there, or maybe some blocks, endotracheal tube is blocked. So that time you need to have that properly suctioning has to be done, and frequent suctioning it's not recommended because it increases the chances of infection until unless it is required. Okay. So, and it also causes the tracheal trauma if you do frequent suctioning without any reason. So without reason, you should not do frequent suctioning. If there is a secretion frequently coming out, then you have no other option to do the suctioning. Okay. So next question is how to manage ET tube in neonates. The same process with the neonates also, but there is a sizes that varies of a tube and the laryngoscope. Even if you don't find the laryngoscope, the kids intubation is quite easy because you can put it by just lifting the pallets just by your fingers. Your finger can work as a laryngoscope, but you have to have that visualization with some kind of light source has to be there, the torch or maybe like that. But it's better to go for a laryngoscope if you have, and only size that matters, because and rest of the process is the same for the neonates. And how many times we can try for intubation at a time? So see, you can try intubation because until patient is giving you time with the pre-oxygenation with the oxygen reserve, if you have a patient having oxygen reserve, and but you have to be very careful not to give the trauma to the airway. So by frequent insertion of the tube might give there will be chances of laryngeal edema, and that makes further difficult intubation. So it's better to, once you have failed to intubate, let's not retry it and keep on ventilating that patient with a bag mask ventilation and call for expert help. Okay. And you can ask someone else for the intubation who is more expert than you. So you should not try more than once or twice maybe. Okay. How will we prevent ET block? By frequent suctioning. If there is a chances of secretion is frequently coming out, you have to do the frequent suctioning. Otherwise, it's not recommended to suction the patient, do the suctioning, unless there is a blockage or unless there is a excessive secretion coming out. So in case of maxillofacial trauma, especially Leaford type 2, the intubation done directly by cricothyrotomy or submental intubation. Yes. In case of the facial trauma with that Leaford grade 2, intubation can directly do with the cricothyrotomy or submental intubation. Yes. When cricothyrotomy will be replaced by tracheostomy, unless the expert arises. As soon the expert arises, we should shift it to the tracheostomy, because cricothyrotomy and the LMA devices, subglottic, supraglottic devices are just breathing devices. Which mode of mechanical ventilation to start? See, there are support ventilation. There are two kind of ventilation. One is support mode and assist mode. Okay, assist mode and support mode. So if the patient is awake, or he can has an effort to breathe himself, so we can give him assist mode. But if the patient is completely, he cannot breathe himself, then we can go for a control mode. In a control mode, there will be two kind of ventilation. There is a pressure support and volume support. So we can choose according to the patient condition, which one is recommended for that. But if the patient is already sedated and paralyzed, we must go for a control mode ventilation, be it a pressure or volume. So more of we go for a volume pressure control. Yeah, we go for a control mode ventilation, be it a volume or pressure, depending upon the condition of the compliance. There is many factors that we have to assess to go for us when we are selecting the mode of the ventilation. We have to see the patient's breathing effort. Is there a patient is in a having labored breathing or accessory muscles are involved, or the patient need fully uh, sedation or paralytic agent. So in that case, we have to go for a control mode. Okay, and there are some modes like which a mix of volume like PRVC, pressure related volume control. So there are pressure and volume both are controlled in a like we have to set pressure and volume both in a ventilator, and that is given by the ventilator. There will be no effort from the patient side. So we have to sedate and paralyze the patients for to work this control mode ventilation. Okay. Yeah, soda bicarb, it prevents the blockage, and we use it while suctioning if uh, there is a huge or a tight clog there, I mean, obstructing the airway. And this is not coming just simply by suctioning. So we have to put the soda bicarb and do that ambu bag, and then we can suction it. It comes out very easily after using the soda bicarb. Yeah, we quite often use it in ICU. So I think that's all are the questions till now I have which I have seen.
Yes,
And
Doctor,
yeah,
Dr. Ratan Mekla says, thank you, sir, for delivering such a clear and insightful presentation on airway management. The systematic approach, practical tips, and case-based discussion made the complex topic very understandable and clinically relevant. Your depth of
thank you so much.
knowledge and teaching style are truly inspiring. Looking forward to more such excellent academic sessions from you. Thank you so much, sir. Dr. Ratan
Thank you so
Mekla,
much.
from Mediversal, we promise you to bring more such webinars from Dr. Kunal Kumar. We really thrilled. Feedback like this moves us, pushes us to bring out the best in the field to make these such sessions. Thank you so much, Dr. Mikla. And
Thank you so much.
yeah, about Dr. Kunal, I already said he is under kind of tremendous pressure, and yet sitting here in front of you, explaining every slide with utmost care, not even making it faster. He took ample of time to explain you. Thank you, sir. Thank you so much. Yes.
Thank you so much.
Dr. Sanjay Kumar says, sir, please make video links available. Dr. Sanjay, sure, we'll see what we can do about that. Kirti, thank you, sir. Please, Dr. Sanjay, if you are following our groups, we'll try to send those links to you in the group. That is one way possible. Uh, Dr. Ratan says you are truly inspiration for young arts. He is. He truly is. He truly is.
Thank you so much.
I think, sir, we are at the end. So now I'll be sharing the certificate link where you can register for the certificates. Dr. Supriya, yes, Ms. Supriya, we are sharing the link. You've been asking for multiple times. Yes, we are sharing the link now in a bit. Thank you for joining the session. So the link is in the chat box. Now, please, Dr. Kirti, I think there has been a miscommunication for you. All our webinars will be given participant certificate to everyone. Just that you might not feel. Reach out to us. If anything is missed, we will get it back to you. Don't worry, not to worry. If you have attended the webinar, you should get a certificate. So reach out to us by any means. We will arrange a certificate. But yes, please do fill the form to get the certificates. The certificate is in the chat box, and we will be so please fill the form. Great. Thank you, doctor. Thank you for this insightful session. I personally learned a great deal. In fact, when you were showing the video about, I can share my own personal experience here. My grandma, I don't know what she was diagnosed with, but uh, you were talking something about LME. It was inserted on her throat. I had a very personal touch when you were explaining that. So, and I'm sure all the doctors here would agree with me. On behalf of everyone, I extend our sincere gratitude, Dr. Kunal. It's kind of the engagement and participation that motivates us to organize more such webinars in the future. One small request is when you open the link, there is at the last, there is a section to reviewers. Please review us on Google and send us the screenshot to get your certificates, because your feedback, your rating about us on the session gives us an immense energy to reach out to that extent where we can bring on all the uh, experts in the field to teach you. Also, we have one more session on July 23rd based on ChatGPT for professionals, because now it's a AI world. So everything is moving with AI. Now the doctors also moving with AI. Now on 23rd of July, we will explain you. It's a purely technical thing, nothing, no here and there, completely technical. How to use ChatGPT, what is the art of writing prompts, how you can enhance your time, how you can simplify your daily life. Everything will be taught on July 23rd. Please do be avail yourself and join us on 23rd at 7 p.m. And a person from IMK, also a co-founder of Mediversal Academy, Mr. Subramania, will be taking the session on ChatGPT. He himself is an AI enthusiastic, and he teaches you a great deal of ChatGPT. Now, to end all, thank you for all joining us today. We hope you find this webinar very informative and valuable. I'll be dropping our social media channel links to follow us, where you can get to know about all our upcoming webinars. There are so much planned. There is so many sessions as planned for this month. So please do follow on social media. Also, I'm dropping you our WhatsApp channel link. We'll be launching quizzes, we'll be launching case series, and all the case series answered in Instagram will be provided with the certificate to help you with the CME points. So please do follow our social media channels. Please do follow our WhatsApp channels to stay updated on this. Uh, Thank you so much. Thank you for joining. It was great session, and I hope you all agree here. Thank you, Dr. Kunal. I don't.
Thank you so much. I think I need to go now,
Yeah.
because
Please, please.
you have to take the rounds, and it's time for me to take the rounds now.
We are ending the session here. Thank you so much, Doctor.
Yeah. Thank you so much. Thank you so much.
Thank you, Doctor. Thank you.
Thank
Thank you
you.
all. Good night. Have a nice day.
Good night.